right. Instagram is live. It's gonna wait it. Okay, what's up? People are coming in. Welcome everybody. Thanks for joining tonight or this morning or wherever you may are, what time it may be, wherever you may are. Welcome to today's live stream. We're going to be joined today by Nicholas Rollnick, Dr. Nicholas Rollnick from the United States, based out of New York, who is going to talk about blood flow restriction training. Good to see so many people rushing in. We're going to wait for Nicholas to request to be in this live stream. So for those who just got the notification that we're live, this topic today is going to be blood flow restriction training. What's up, Greg? Blood flow restriction training with at the HPM. Whoop, is it going away? I want to pin this comment. There we go. So I pinned the comment. Okay, wait, I just saw the request. Go live with Nicholas Rollnick. Add Nicholas to this. We're going to wait for Nicholas to join us here in this live stream. Again, for all of the people who just joined, what's up, Nick?
What's up? How's it going?
Good. How are you?
Doing well.
Just giving a short introduction. I don't know if this is going to cut off my face a little bit. It's just giving a little introduction on, for those people who don't know, who haven't set a reminder for tonight's live stream. We're going to be talking about blood flow restriction training. Nicholas, I think arguably one of the experts on social media on the topic, posting a lot of valuable content day in and day out on research and clinical application of this, not recently developed. I think there's been quite a lot done on blood flow restriction training, but a lot of people still don't know about it. That's why I think today's live stream is going to be, a gem full of valuable information for those who tune in. So maybe, Nicholas, I want to give you the chance to introduce yourself to the audience. For those who don't know about you, maybe give them the cliff notes.
Yeah, so everyone, I'm a physical therapist from the United States. I have a practice in Manhattan. Really, my philosophy as the human performance mechanic is helping my patients experience the joy of pain-free movement. And really, for me, it's all about movement. So I'm a very exercise-biased therapist. And so blood flow restriction, when I came across it a couple years ago, really, honestly, as a student, it really kind of opened my eyes to what we can do to push the human body to force adaptation. And so I really got into blood flow restriction in the last 2.5 years. And, the research now as BFR we're having awesome results with our clients and patients worldwide. And the research now is coming out to back this up. It's really quickly becoming mainstream. And as you mentioned before, blood flow restriction actually was founded in Japan in the mid-'60s. And it was quite literally a Japanese bodybuilder who was sitting down on ankles to back of the thighs and started to feel a little bit of a burn in their calf. And physical therapists were like, "Oh, is that sciatica?" Well, for him, he was like, "Oh, this is like similar to the type of burn that I get when I exercise." And he was like, "All right, well, as bodybuilders, we're a crazy breed of people." Me being a bodybuilder, I competed in 3 different shows before I was a physical therapist. This doesn't shock me. So pretty much what he did was he wrapped a tourniquet, wrapped an elastic band around his leg and started to exercise. And literally that was the birth of Katsu training. And so blood flow restriction now has been in Japan for quite some time. The research initially started to appear in the late 90s with application to normal individuals, and then recently now, as it's established its safety profile, and we're learning about all these different ways that we can apply this stress to the human body. It's now gone into professional athletics. It's now gotten into the rehab population, and obviously the fitness goers. So, a little bit about that with myself. So me as the human performance mechanic, very passionate about blood flow restriction because I can use exercise at low loads, which we'll talk about in a second, to help my clients and patients experience the joy of pain-free movement and get them back to what they love to do, and in many cases better than what current management strategies are. So that's kind of how BFR has fit into my own my own practice.
Perfect. So for those in the live who are watching right now, we gave you guys I think a lot of time to ask questions. We posted multiple question stickers in both our story and your story as well, because we wanted to not only have this presentation sort of live stream, but we wanted to be able to really provide value to you guys and answer the questions that you have about this modality. So we went ahead and we collected all of these questions, and to sort of give a framework to this live stream, we took the 7 most commonly or most often asked questions that will guide sort of through this live stream. But don't be afraid to post some questions in the comments down below. At the end, we want to also give the time to answer some live questions. We're going to go through that. But yeah, don't be mad at us if we can't answer all of these questions in this sort of 45-minute, 60-minute live stream. So Nick, you already talked a little bit about the origins of blood flow restriction training, the history, how the concept developed. You were talking about the Japanese origin of the Katsu training, but you were talking. This guy, he experienced this burn that he would otherwise experience in training. So can you maybe talk a little bit about the proposed mechanism? Why is it such a valuable, or why can it be such a valuable tool in rehab or in sports performance enhancement, bodybuilding, whatever? What does it come down to when you apply blood flow restriction or occlusion to your limbs and then train? What are the mechanisms?
Yeah, that's a great question, because so in essence, really what blood flow restriction is doing is it tricks your body into building muscle mass with lighter loads. Like, that's the general, easy to kind of convey perspective. But now we have to get into how does it do that and why is that beneficial. And so, because our bodies, really our muscles, are very non-specific tissues, meaning as long as they only contract and relax. And so the feedback that our brain gets will then help dictate our response to exercise. And so what blood flow restriction is you're applying, in essence, a tourniquet. And in the United States, what we want to use something called a Class 1 tourniquet that's designed to restrict blood flow. But this tourniquet then is applied to the arm, or it's applied to the leg in the closest part of the arm or the leg. And it reduces blood flow to the arm and completely restricts venous return. And so what ends up happening is, as you start to exercise, this traps the metabolites, so the byproducts of exercise that would normally get cleared from a non-restricted exercise. And in doing so, now you create an energy demand crisis, because you're not getting as much oxygen to the arm or the leg. And then so when we're lifting weights now, we don't have where we normally would be able to clear these metabolites and be able to get oxygen back to kind of re-energize our muscles. Now we don't get that to the same degree. And so with this energy crisis that's now the short-term energy crisis that's happening, we get a shifting in the energy metabolism. So where normally, if we're using oxygen to be able to fuel light load contractions, for example, now all of a sudden these muscle fibers are not getting that enough oxygen, and so based on what we call the Henneman size principle, right? We're going to have to go over a period of time to be able to recruit some of those type 2 fibers, those fibers that wouldn't really normally get stimulated at this very light load, because if we were able to contract pretty much indefinitely with light loads, now we're never ever able to tap into those muscle fibers. And so with the reduction in oxygen to the arm or the leg and the restriction of any sort of metabolite clearance, we have to recruit those muscle fibers now at very low loads to be able to get stimulated. And now the interesting thing is, like our muscles literally are only getting the feedback to contract or relax. And so with the restriction of this, that provided by the tourniquet, our brain thinks there's a very stressful exercise that's happening because we're getting a significant buildup of these metabolites. And that's what's driving a lot of the high levels of growth hormone that we're seeing, high levels of muscle hypertrophy, for example, because all of this at the end of the day is going to make it so we can accelerate fatigue, because fatigue is what it drives adaptation at the muscular level. And so we can then do this. We can do this in all different populations now. So you mentioned bodybuilders, rehab, etc. So because our muscles really are a very non-specific tissue, that means that we can fatigue them. They're going to adapt, right? All blood flow restriction is doing is accelerating that process to happen at light loads. So normally, if I'm able to lift, a bicep curl with 5 pounds for 150, 200 repetitions, I can then cut that in a third and accelerate the ability to generate that fatigue and get that adaptation. So that opens up a whole plethora of opportunities for individuals to, across the spectrum, elderly, athletes, post-operative clients, to be able to now get hypertrophy in situations where they might not necessarily be able to do that for one way or another. For example, my most recent posts were talking about the elderly. If those elderly are contraindicated to lift heavy, right? Now all of a sudden, these individuals are not going to be able to stand there for 20 minutes to be able to do a leg extension with 2 or 3 pounds, right? But we can then use blood flow restriction to accelerate that process so they can get a training effect. So you're talking about...
Can I tap in?
Yeah, for sure.
Yeah, can I tap in there? Because now that we're talking about the elderly especially, I guess with them, certainly it's a little bit about being able to train safely. Maybe they're a bit more frail than the other population or a different population that we see, such as athletes, younger people, that maybe we can expose them to, very high loads, but still get a good training effect and stimulus out of our sessions. You were talking, okay, maybe are they contraindicated? People are contraindicated to lift heavy, but especially thinking about the elderly, thinking about vascular comorbidities, and we're talking about occluding venous outflow from the body, from the tissue. Do we have to think about something else in that population, about contraindications, not only to lift heavy, but of applying blood flow restriction training with them?
Mm-hmm. Yeah, I mean, so the elderly can benefit tremendously from blood flow restriction if they fit, the indications. And so I like to think, I teach blood flow restriction nationally in the U.S. and internationally. So really, you have to harp on this. And when I speak to other clinicians and practitioners, it's that if you understand that what you're doing is you're applying a tourniquet, just like what you said, to stress the venous system, but also the arterial system, well, then if you look and say, all right, well, what conditions, if individuals have problems with their oxygen delivery already, for example, if they have ischemic arterial disease, well, blood flow restriction is probably not going to be something that you want to do with them. If they have any problems with the venous system, for example, venous insufficiency, they're not able to clear this anyways, well, then obviously blood flow restriction training is not going to be for them. If they have problems with like any sort of indications where, you know, they have like an open surgical wound, or they have infection. Things that you would anticipate would be contraindicated are probably going to be contraindicated. The big things here to understand is that if you're able to use, you know, pretty much honestly common sense for the most part, then you can safely apply blood flow restriction in this population. The only thing I would say is, as we, you know, there are precautions, like diabetes, for example, any other conditions where hypertension, like things that where, you know, as we get older, you know, the elderly individuals tend to accumulate more comorbidities, and so it doesn't necessarily become contraindicated per se, but it becomes a judgment call. So from the clinician's perspective, looking at that client and saying, based on your, for example, like here's what I would do. I'd say, all right, an individual is coming in with knee pain, for example, and 75 years old. You know, the research right now has stated immediately absolute contraindication is a prior history of a blood clot. Right? Even though from a safety perspective, you know, we've already have tons of evidence, because really the first initial batch of studies was actually done looking at safety and showing that really blood flow restriction does not elevate the risk of blood clots. In fact, it actually promotes breaking down blood clots, similar to what it would be for high intensity training. So I'm not really concerned about a blood clot per se, but as of right now, it's been adopted as an absolute contraindication. So if anybody in the screening process, I'm saying, hey, have you had a history of a blood clot? Then yes, that would absolutely be a contraindication. Then next, it's looking at, all right, what is their status? What is their current health status? Looking at their comorbidities, but also factoring in that blood flow restriction exercise is stressful. This is not a walk in the park, you know, in rehab. I see people doing the leg extensions and they're chalking, they're having fun, like whatever. No, this
is on their phone or whatever.
Yeah, this is a stressful exercise. This is not fun per se, but that's how you know that it's working, right? As soon as we start to experience that metabolic burn, that what we would colloquially call the lactic acid burn, which really isn't lactic acid at all. But that's actually when the exercise set should really start. So you screen out those individuals. You then, for me in the elderly, I tend to I want people to that will benefit from blood flow restriction long term to be able to actually get involved in the process. So what that means is I don't want to crush them from day one. I want to use an acclimation period to be able to have them get comfortable with the stimulus, because you know what, it is a unique stress. Right? If somebody has never exercised before and they're a geriatric client, and I think that blood flow restriction can actually help in their plan of care, I'm going to be very, very, very careful at grading that exercise, because when people say, I don't know how many physical therapists, athletic trainers, people that work in rehab or even fitness are watching right now, you know, people have a tough time differentiating between pain from an exercise like a lactic acid burn and muscle soreness versus a very bad effect of like excessive pain, etc. It's very hard for the individual that has never exercised before to actually differentiate the two. So I tend to make sure that that I can acclimate them to the stress very appropriately. Why? Because the research actually shows that because blood flow restriction is such a unique stress. So typically I like to give this analogy. Normally when people exercise, they're on one end of the spectrum, which is the traditional recommendation for hypertrophy and strength is greater than 65% of the 1 rep max, right? So this is very high mechanical stress to the muscle and the muscle fiber. Then on the other end is what we would consider light load training. And that promotes substantial metabolic stress, but not which also at the end of the day will stress the muscle fiber itself over a period of time. And we can get into talking about that if that's something that we want to get into. But very high metabolic stress. Our bodies usually, because people train on this end of the spectrum, are not used to training on this end of the spectrum and pushing their bodies to that degree. So in the initial application period of blood flow restriction, there's actually significant muscle damage that can occur from the initial use. But the cool thing is after this period of acclimation, you don't get significant levels of muscle damage at all. So once you get these individuals acclimated to the stress, you can push them very, very, very hard and know that really they're not going to get sore, which is awesome from an exercise perspective and awesome from a self-efficacy perspective and awesome from an empowerment perspective of knowing that these patients now who weren't necessarily being able to, for one way or another, especially in the elderly, push their bodies to really force that adaptation. We're able to do that in a low load situation to get these people feeling like, oh man, I feel my quads again for the first time in years, and I'm not sore in my knee after. I mean, when you hear that from a practitioner perspective and you hear these individuals say, I'm getting my life back. I mean, these are things that drive me and really, get me up in the mornings and helping people enjoy pain-free movement and getting them back to what they love to do. And so for the elderly, it could be as little as just being able to be independent in their own house, but also being able to, or in the most recent videos, deadlifting, getting back to deadlifting, right? Like it's really, really, really cool from that perspective. So
very non-specific effect of training then. I mean, there's a big systematic review from Scandinavia on osteoarthritis, not talking about blood flow restriction training, but generally that the biggest effects in global perceived outcome were non-specific and then not related to any exercise program or any gain in muscular strength that these individuals got from participating in that trial, but most of the effects were non-specific, and I guess that's also what I guess using BFR also allows those individuals to experience, like what you said. Okay, I can feel my quad again. I think I can train again. I can get back to training without suffering from these, let's call them, side effects that I used to with my traditional training or my traditional rehab approach. You were talking about, we were talking a lot about now the elderly, but could you give some examples? I think you have a lot of experience working with different populations and applying BFR in different populations. Who else can benefit from BFR? I can imagine we tapped into like post-operative patients, others like the total knee replacements, total hip replacements, or because you said, okay, we apply it, maybe we can do that like a 2-in-1 question, because we can only apply it proximal on the limbs. There's no trunk, there's no we can apply it on the trunk or a distal application, I can imagine. I guess then the population seems on first hand kind of limited to training the extremities distal to the application of the cuff. Could you talk a little bit about that?
So I just saw one question about, could you explain what BFR is for the new members who join us live? So just blood flow restriction, in essence, what it is it accelerates the process of fatigue at lighter loads. So you can then train for, say, like a 5-pound bicep curl and get similar muscle mass gains as you would if you trained higher loads. So it's really cool because it opens up the opportunities for individuals to get back, recover faster. Our motto, as I am also a co-founder of the BFR Pros, and so what our motto is accelerate human performance and recovery through blood flow restriction. And so really, honestly, there could be populations of all demographics that could benefit from inclusion of blood flow restriction. So we've just basically talked about muscle mass and strength, but really you can do blood flow restriction low load walking, for example, and walking can improve VO2 max, which is a vital sign, right? So it opens up anybody. I mean, obviously the most applicable is elderly, but really there have been studies on athletes in Korea, college athletes looking at individuals walking on a treadmill, improving their VO2 max. There was a study on military elite paratroopers. Ursprung in 2017 was looking at elite military paratroopers walking on a treadmill that improved their 1.5-mile run time. It's really the adaptations come from oxygen delivery or reducing the oxygen delivery and then getting all these benefits. So when we talk about, I'll give you a couple examples of individuals that could benefit from blood flow restriction that are not just the elderly. So we talk about in post-operative, you mentioned, right? The thing with post-operative is you initially, when you don't move your limb, whether or not you're bedbound or you're just immobilized, you are going to rapidly atrophy. Our muscles are metabolically active tissues. They release literally chemicals, growth mediators into the muscle itself, but also into the bloodstream that help signal and pretty much maintain our metabolic health. And so if we're not contracting them, it's the true adage of use it or lose it. So when we're following post-surgery, right, we can experience rapid atrophy in our muscles. Something like within 2 weeks, we can experience like a 10% loss in muscle mass. So if you make a fist, right, that's about the size of the human heart. That's about 350 grams of tissue. That's how much we can expect to lose from immobilization, and that's not good. And then you pair that on top of the loss in muscle strength that will come from a reduction in muscle protein synthesis, because if we're immobilized, we're not exercising, so we can't influence the protein net protein balance curve that way. We're probably not eating well, so we're not able to emphasize it that way. And so now we have a rapid reduction in muscle strength and muscle mass, which leads to something that we don't want to ever get, which is anabolic resistance. And so anabolic resistance is just that our muscles become less sensitive to the effects of exercise. And that's not good when we're talking about muscle being a metabolically active tissue. So what blood flow restriction can do in the postoperative immobilized client is we're able to stimulate muscle protein synthesis from very, very, very low load activities that would not stress the surgical site. So for example, if you have an ACL rehabilitation, right, the surgical scar is typically pretty low. And pretty small. And so what blood flow restriction we can do now is we can facilitate quadriceps recovery as soon as possible following surgery, because rapid quadriceps atrophy is a huge problem in ACL reconstructions. And the most recent studies have looked at really like 2+ years following ACL rehab, there's still quadriceps, what we call hypertrophy, or a lack of muscle mass in the affected or in the surgical side. So what we can do with blood flow restriction is get them moving really quick, even by the application of the tourniquet itself, to promote what we call a cell swelling effect, which pretty much what that does is it just pumps up the muscle, and in doing so we can create some attenuation of muscle mass loss. So we're never going to, in a passive sense, without muscle contraction, actually prevent the loss of muscle itself, but we can attenuate that. And that even goes to a recent study that was done in 2018 that was looking at comatose patients. And all they did was put blood flow restriction on one leg, and they did the passive 2 sets of 15 of knee mobilization. So right, they were just flexion and extension of the leg. And they compared that to flexion extension of the leg without BFR. And they showed that they could give that individual another 3 days before their quadriceps or their leg atrophied 20%. Which again, think about that. Wow. In 9 days, that the individual that was bedbound, right, in a comatose state, atrophied 20% in 9 days. Blood flow restriction, by just putting the cuff on for that short period of time, increased that 3 days. So this is not talking about active NMES, et cetera, and we already have evidence to show that adding electrical stimulation can also help with attenuation of muscle mass. But really, that's the postoperative client, right, where we can then accelerate their performance and recovery faster than what we're doing. Do you have a
timeline? Because there was a question actually regarding ACLR rehab. Is there a certain timeline? I don't know if that has been taken up in sort of rehab protocols for postoperative ACL tear patients. Like when can you start applying it?
So that's the question I get all the time. And let me just tell you. So I go and I speak with surgeons. And they voice the recognition. First of all, number one, even though blood flow restriction has been around since the 60s, it's now just starting to become mainstream. So not a lot of physicians, not a lot of surgeons are aware of what blood flow restriction actually is. And so it takes a lot of education for them to feel comfortable with, hey man, actually reducing oxygen and increasing, that allows the increase in muscle cell to be able to increase hypertrophy. And so, they're concerned that restriction of blood flow could lead to a blood clot. And so it takes a lot of evidence presenting evidence to be able to say, hey, listen, like actually the application of a tourniquet is not an independent risk factor in the surgery itself. It's going under surgery is the actual risk for a blood clot. And so that it takes education on that part, number one. And number two, every surgeon is different. So I'll give you an example. Some surgeons do not want blood flow restriction until 6 weeks post-op. Why? Because the research shows that just in the first 6 weeks following surgery, there is an increased risk of blood clots, irrespective of anything. And so if you look at the most recent article in the JOSPT about blood flow restriction, they actually talk about that, that just general risk of getting a blood clot in the first 6 weeks. I've had other surgeons feel comfortable with 2 weeks and 4 weeks post-op. So it really just depends, and that's why when people say, "Oh, when do I want to use blood flow restriction?" I think honestly, it's a great opportunity for you to reach out to the surgeon and reach out to your referral source and talk to them. If they haven't heard of blood flow restriction, that's a great opportunity for you to get in the door and be able to explain to them what it is, because I think that this is going to change the way that we manage early to moderate post-operative periods, because we're able to stave off some of that atrophy that's going to occur following the decreased use of that limb. And the only other thing I will say is the surgeons that I've talked to, they're very worried about a physical therapist making a unilateral decision on the plan of care without letting them know. So if you are feeling that you are going to, or you think that blood flow restriction is going to improve your quality of care, which I will say it probably will, because I think of blood flow restriction as being better for results. So BFR, better for results than what we're currently doing. I mean, I didn't get a chance to do my little spiel. BFR is, when you understand what's going on, BFR is, under a certified provider, BFR is easy to use, hard to misuse, it's safe, and then it's better for results. So especially in the early post-operative period when we're trying to stave off as much atrophy as possible, blood flow restriction would be an appropriate thing to be able to do. Yes, that was from the Barbalo 2018. Yes. There's just a lot of ways that we can integrate that, and that's talking nothing about the athletes and how we're approaching athletes with blood flow restriction as well.
But maybe now you mentioned, okay, maybe the surgeons are they're a little bit scared of if they also due to not knowing what BFR actually is, that they're concerned about complications that might result from applying it. But you are very versed in the literature on the topic. What are you concerned, if there are any concerns from your side, when or whether or not to apply BFR in a patient? From your perspective, where do you see, okay, that's for me an absolute no-go? You talked a little bit about it in the beginning, but maybe to just go down the list of, okay, somebody comes through the door, is he or she a potential candidate for BFR? Yes or no?
Yeah, no, that's a great question. So I think first we got to go back and we got to look at, for me, it's the technology, right? Number one, because really what blood flow restriction overall in the non-clinical populations is pretty safe. I mean, unless you're going to be doing blood flow restriction for 45 minutes and not letting reperfusion happen, it's really a safe way to approach exercise if you do it and you understand what you're doing, right? That's what I'm saying. Under the guidance of a certified provider, BFR is easy to use and hard to misuse and safe, right? So the first thing comes along the lines of that. Now, the second thing would be the actual technology itself. The research really, and I fully agree, that what we should be doing is being able to standardize the pressures to the individual, meaning that when I do blood flow restriction, right, if I'm looking at doing something like a quadriceps extension for a post-op ACL client, right, I want to know what pressure is what pressure I need to use to be able to get an optimal stimulus. And what that means is I don't want to have a pressure that's way too high, because if I have a pressure that's way too high, that actually is known to be way more painful. And the pain itself might actually stop their exercise performance before you actually get the maximum gain. But I also don't want to have a pressure that's way too little, like something that's not able to restrict arterial inflow, because then I'm just going to be there doing leg extensions all day, right? So there's a healthy medium, and how you get that healthy medium is through having cuffs that are able to adequately compress the limb. And typically those cuffs are using a wider cuff, right? And they're able to do some sort of technology, whether that is like the Delphi unit, which has a pressure sensor that's built in that can actually look at what the individual's limb occlusion pressure is, or from other cuffs like that use a Doppler, that you're able to then use an external Doppler, which will then tell me exactly, all right, what pressure is that individual stopping blood flow completely. And what that means is the limb occlusion pressure is just the minimum pressure needed to completely occlude arterial and venous flow. And so what we do is we exercise at a percentage of that. So typically when you have a wider cuff, you can exercise at less pressure, relatively speaking, which would be safer overall. So a cuff that's a little bit wider, and that we can standardize the pressure. And then after that, then it's looking at integration protocols. So looking at, all right, well, this individual now has never exercised before or is early post-operative. How is that going to then fit into my plan of care? And that would vary on a patient-by-patient basis. But at least at the bare minimum, what you want from a clinical side is you want something that you're able to standardize the pressure to the individual. Whatever technology you're able to use at whatever given point is ultimately up to you. But I think from a clinical perspective and a liability perspective, the research is pretty clear in that we need to standardize the pressure to the individual.
All right. So, I mean, the modality sounds great, right? Safe training in terms of, okay, mechanical load, but also metabolic loads, very accessible, seems accessible. But now the patient comes through your door. Do you have the cuff in hand and you're like, screening for any contraindications? Okay, then I apply it. Or do you still also opt for, regular progressions, maybe from, advancing from isometrics to some low load concentric, and then maybe later on incorporating more eccentric movements and going to more high load trainings? Where do you decide, okay, am I going to go with BFR or more of like traditional methods, or do you just, directly go to BFR? What are the significant benefits or maybe downsides compared to traditional methods of training, maybe also depending on the population you're working with?
Yeah, that's a great question. So I honestly, blood flow restriction is a tool, right? It's not my sole approach to rehab, because yes, blood flow restriction can make a significant impact on the lives of my clients and patients, but ultimately, right, it has its limitations as well. So typically when somebody walks through my door, right, the first thing I'm looking at is assessing the situation in general. I'm never thinking blood flow restriction, number one, because again, it is just a tool, and it's a tool that I can use effectively given the right situation. So if somebody then fits, for instance, if they're post-surgical and they're looking at, all right, well, I'll give you an example of a client that I just saw on Friday. They're 2 years out of a quadriceps tendon repair, and they're still experiencing long-term pain and some atrophy in the quad. Well, the issue is, obviously we know that in order to increase quadriceps mass, we need to stress the quads significantly, right? The issue then becomes, if there's pain with heavier loading, well then it might not necessarily be the most appropriate call to be able to get them to heavy loading. But ultimately, my job in this client then is to use blood flow restriction to give them some quadriceps mass, but ultimately transition them to high load training. Because that person is an athlete, they want to get back to playing soccer, etc. But ultimately, really, we have to think about blood flow restriction as just a tool in the toolbox. So typically, in the early periods of time when if I'm seeing a postoperative client or somebody like that may be contraindicated to lift heavy, because ultimately lifting heavy is going to confer the largest amount of benefit to the bony anatomy as well as the tendon anatomy, which is a really important thing to consider when you're talking about tendinopathies, because tendons, unlike muscles, are extremely, extremely specific, meaning that it takes a prolonged period of time, at least 8 weeks, with high intensity loading, whether that's isometrics, eccentrics, concentrics, it doesn't matter. The tendon needs to experience stress. And with low load blood flow restriction, the muscle is experiencing a significant stress, but the tendon really isn't experiencing any stress at all. And so if I have a client that I'm suspecting it's a tendinopathy and related to where I'm seeing them, I am actually not going to do blood flow restriction with them, probably at all, because I know that blood flow restriction is not going to influence the actual tendon, the issue itself. So it really just comes down to understanding what, where, once you understand, and that's why I really try to harp on in my posts, that blood flow restriction really is just a tool. It's a very effective tool, but it's just a tool nonetheless. So ultimately my thing is I want to bridge everyone to their maximum capabilities. So in the elderly, harping back to that, if they're contraindicated to lift heavy, for example, for a balance/falls risk, then obviously I'm going to use blood flow restriction with them because I can facilitate as much muscle mass and strength without having to worry about them falling. If it's an athlete, right, and they're acutely injured, I want to make sure I'm mitigating as much muscle mass loss as possible. And so I'm going to use blood flow restriction with them ultimately to bridge them back to heavier lifting and velocity-based training, because that's what's going to transmit to them in their sport. So ultimately, it really just depends. It's the physical therapy answer. It depends. But I never actually look at blood flow restriction as somebody, oh, I'm seeing you and you're going to come into my clinic and we're going to do blood flow restriction only. That doesn't really work. I would say I only have about 40 to 50% of my clients that actually use blood flow restriction because they're either otherwise looking for performance from a velocity-based or heavy strength-based training routine, or they're just inappropriate and they don't fit the indications for blood flow restriction. They have one or more contraindications or two or more precautions in my mind.
Okay, so yeah, we know we did a tendinopathy series, I think 2 weeks ago, 3 weeks ago, where yes, it was discussed tendons, they only adapt under heavy loading. But yeah, I guess there's always a muscle attached to that tendon. We can't change tendon matrix with light load, but we can of course strengthen the muscle itself, create hypertrophy in that muscle. So you said, okay, if I suspect tendinopathy, I will not apply BFR. Is that like a hard no, or is it maybe a possible adjunct to work on hypertrophy to build out muscle mass and strength, and then use?
Yeah, I mean, so that's a good question. So if you look at the adaptation profile between muscle and tendon, muscle with especially if you're looking at a potentially high frequency BFR, you can look at getting muscle hypertrophy in as little as 2 to 4 weeks. Tendons, on the other concern, and the concern the tendon researchers that I've spoken with are that we can create a significant muscle tendon imbalance, and potentially, if we're just using blood flow restriction, could potentially have something in a worst case scenario like an avulsion, because the muscle becomes so strong and the tendon, the stiffness of the tendon is insufficient. And so it doesn't concern me in terms of like an avulsion issue when we're dealing with a population like the elderly, because, for us, it's all about improving their function and quality of life. I don't care if blood flow restriction is, because unanimously already, if you compare blood flow restriction to blood flow restriction low load and you match reps, blood flow restriction blows them out of the water. And you also look at the time to adaptation, et cetera. All this stuff is in favor of blood flow restriction. But at the end of the day, like, I just care about, does it improve their quality of life, right? versus something like a bodybuilder or other athletes where, you know, I talk about this 80-20 rule. And I really firmly believe that, you know, that if we can just maintain in populations that are able to lift heavy, you know, about 20% of the volume being heavy loading, so we can maintain that tendon stiffness, we can maintain the bony health, well, then we can maximize the hypertrophy and also keep those neurological adaptations that are specific to the strength training. So that's ultimately where I see the longevity piece of these individuals that want to maintain their, you know, be active long term, but don't want to stay in the gym and do bicep curls for 50 minutes to gain that adaptation without stressing the, you know, the joints. So,
all right. So, Nick, let's see. Okay, I come to your clinic. I'm your patient. You know, you went through your subjective, and I meet the criteria. No contraindications for applying BFR. You see me as like the ideal candidate for administering BFR in my rehab. Can we maybe like run through the process of how you would then administer BFR in a patient? Like, what is your process in terms of maybe defining the rate of occlusion, the degree of occlusion in the patient, and then how do you get me used to the metabolic stress that we're going to create?
So I just want to answer that one question about muscular endurance. So so they were asking about what is it for muscular endurance. So really, honestly, if you just train BFR to failure, light load to failure, it's going to outperform like high intensity training to failure in terms of muscular endurance. It's the specificity principle at work. So blood flow restriction is not going to outperform high intensity training with respect to force output, like a back squat, for example. But when we talk about increasing muscular endurance, I think Lenike's group actually looked at some of this in their, I actually posted about this on my feed, so you can go check it out. It's one of the blue posts that was looking, I think, at 15% of the 1 rep max and looking at improving muscular endurance versus high intensity at 70%. Not. So it's really the specificity principle with muscular endurance. And if you just take it to failure, you know that you're going to get that similar adaptation, and it also is going to be better than high intensity training, for example. So I just wanted to answer that one.
Sure. Great.
In terms of integration, I hate to say it, but it is the old physical therapy, it depends. So I'll give you 2 examples. I'll give you one, since we've been talking about the elderly. I'll give you an elderly example, and I'll give you a bodybuilder / athlete example. All right, I'll start with the elderly example. If the elderly individual has increasing comorbidities, right, increasing in age, fragility, frailty, etc., and my goal is to optimize their muscle mass and strength, I want to make sure that I take an exercise history, number one. So what are you doing for exercise? How long have you been doing it? What is your views towards exercise? Because if blood flow restriction is going to be a part of their plan of care, I want to make sure that they stick to that. And so what I'm going to do is I'm going to start by very low load stuff, meaning I'm going to, take their limb occlusion pressure, I'm going to standardize it, and I'm going to probably start with something like a cell swelling protocol, which is simply I just want their leg to feel pumped up. And the cell swelling protocol merely is, say I want to inflate the cuff to what would be 60% of their limb occlusion pressure. And for those individuals that are just tuning in, that would be the minimum pressure the limb occlusion pressure is the minimum pressure needed to completely occlude arterial flow and venous return. And so I would want to make sure that I'm getting blood flow into the limb, which will create that pump effect and give them that feeling of, oh man. And then I'll probably have them do that for the first session, and maybe add a low load isometric. So meaning like I'll have them contract their quad or pull their heel raise in, or whatever they want to do. That's a very low stress, non-stressful environment, so they can get used to that. Versus, on the other hand, if we're talking about the athlete, and the athlete is, I want to get back to playing. I'm injured. I know what it feels like to push my body to the limit. I know what it feels like to really be sore. And for example, like a bodybuilder, I will crush them on the first visit. So we're going to do versus something like a elderly where I would just have them lie down and just feel the effects of the cuff, right? On the bodybuilder, I'm going to take them through a bicep, tricep, a wrist extensions, all this to really just get them to the point where they're feeling that burn and they know it and it's a familiar feeling and they're like, oh man, I felt this before. I know this is working. And that also creates buy-in from a practitioner perspective, but also it's doing exactly what that is. And I'm not worried on those individuals of them being turned off because they experience significant soreness. So we know that the initial acclimation period of time following 2 weeks, about a couple of sessions of BFR, you're pretty much never going to get sore. But when I just have somebody that I'm coming in for the first visit and they're like, oh, show me about what's this old BFR exercise type deal, and I'm like, listen, you may be sore, but they're like, oh, it's fine, whatever, I know what that is. All right, well, let's go at it. Let's go at it. Versus I do not want that elderly client to be turned off by that exercise that I think, and that we know based on the Centner paper, for example, on muscle mass and strength, and even having them walk with blood flow restriction compared to walking without it, that it can significantly increase their muscle mass and strength. And potentially, with certain studies, we show that it improves their timed up and go, their 30-second sit to stand, all these other markers of function, right? I want to make sure that they can actually, feel the stress, but also not be turned off by it, like what they would be if I just got them under a bar and had them do back squats and they're in pain for a couple of days. So it really just depends on that client that comes in, how I would approach that management.
All right, perfect. But let's talk about the muscle soreness following BFR. You've probably experienced it, but for those who have never trained with BFR, is it that significantly worse than or is it something that people usually have never felt before? Even if somebody says, yeah, I've been sore before, are they surprised of the soreness that they experience?
It really depends. I mean, like I've gotten to people very significantly sore, but it's again just isolated to the muscle itself. It's never, oh, I feel sore in my joint, like from a traditional heavy and high intensity training workout, etc. So it really just it's like I've had the bodybuilders and like, oh yeah, I feel my medial tri so hard right now. I'm like, all right, that's great. I mean, that's what they want to feel because they love that feeling. But other people, it's typically just isolated to the muscle itself.
All right.
Let's see. Is there any other live comments?
Yeah. There's one that I think is also a personal. It's talking about. Can you tell something more about BFR and bodybuilding, especially when to use it and how often? Is it something that, in terms of periodization of training, maybe incorporating it in a deload, or how would you incorporate it in a bodybuilding routine?
So we're working as the BFR pros. We're actually working with some pretty high-level bodybuilders, and how we're approaching this is one of really a couple of different ways. Number one, I still think the 80-20 rule applies, right? We still need, because we know that they're actually, in terms of the muscle level itself, there isn't a lot of physiological changes associated with, for instance, like fascicle angle, pennation angle, etc. We get actual hypertrophy, but some of the heavier load training that is associated with higher demand eccentrics, we don't necessarily get. So you get that with some high load training. So from a longevity perspective, we want to make sure that, and a whole overall health perspective, that you're still, if you're able to lift heavy, you want to lift heavy. So we have these bodybuilders lift, do their heavy routine, but maybe reduce some of the volume associated with that, and then crush them with BFR, because remember, the muscle is a very non-specific tissue. As long as we get them fatigued, which blood flow restriction accelerates that accumulation of fatigue, then they're going to adapt. And so we're able to get a little bit of both. We're able to get the strength, we're able to get the actual changes in the tissue morphology with heavy loading, and then we're also able to really drive hypertrophy from a muscle level without stressing the joints there. So that's one approach, is keeping the high-load training. If they're injured, then obviously we use blood flow restriction a little bit more. And then there's also a third approach, which is we use blood flow restriction prior to their actual loading. So for example, say we have somebody that, this would be an approach that I would use if someone was injured or getting back to it, where we're doing blood flow restriction first, and then we're still going to get load. We might not go back to the, if you're 400-pound back squat, for example, we might not, and you have knee pain, well, we might actually just do blood flow restriction prior. So we do some knee extensions, we do maybe some mini squats or whatever prior to get the muscles primed, so to speak, and then we'll have him back squat 200 pounds. So now you're getting more load, so we're getting more of that, tendon stress, we're getting more of the muscle stress from a morphological level, at least trying to get those adaptations, but we're not having to load as heavy. And that can have a long-term effect on promotion of just being able to stay in the sport, for example, with bodybuilders. So there's a lot of cool things that you can do. And you mentioned before, which I never really talked about it, which is the proximal hypertrophy and what that potentially has on programming. And so I kind of I think that yes, the vast majority of effects are going to be distal to the cuff. But I just want to make this statement, and people can try this as well and see. So typically, for example, if we gave the back squat, right? Ultimately, it's a very quad dominant exercise. We're looking at knee extension being the typical output of how we're able to get back to normal. Well, what if we, in a squat, for example, we fatigued out all of the muscles that will contribute to knee extension in open or, in this case, closed chain. So we're talking about hamstrings, we're talking about adductor magnus, we're talking about the quads. All of these muscles are distal to the cuff. So we're creating a profound fatigue, a localized fatigue response in these muscles, and then we have them back squat. So what are we doing? We're shifting some of the demand now, relatively speaking, to the glutes, right? And we're able to add a little bit more load to these athletes, but being able to then get some of that glute stimulation, because at the end of the day, the muscles don't necessarily care. Now, ultimately, the priority is getting them, if I'd rather them do heavier, hip thrusts or heavier squats or whatever their goal is to get that proximal hypertrophy. But there are ways that we've found clinically, but also now in the evidence. We have Madarame that shows some systemic effects. We have that new paper that was just published that looked at even contralateral effects of BFR that was a study using the Delphi unit. So there's really some interesting things that are going on with BFR, but I don't hang my hat necessarily on some of the systemic stuff, although it does play a role in my exercise prescription when we talk about the post-operative client.
Okay, so the proximal effect, let's continue with the quadricep, hamstring, glute, muscle group in the back squat, for example. So because there was somebody who was asking, okay, where do you apply the cuffs? So yeah, the cuffs are applied on the proximal humerus, right, or the proximal femur, so on the hips or the upper arm. So what you're saying is you pre-fatigue the muscles distal to the cuff so that subsequently when you do regular exercise, the individual has to rely more on the muscle that's not pre-fatigued. So you have a bigger transfer of training effects to that muscle group, right?
Exactly it. And so with the thing that's important to understand too, and Chris Beardsley is actually bringing a lot of light to this. If you don't follow Chris Beardsley, you should follow him on Instagram. He's just providing some great content, is looking at the difference between peripheral versus central fatigue. So peripheral fatigue is actually how that is a loss in force production at the muscle fiber level that's distal to what we call the neuromuscular junction. So this is happening all from the accumulation of at least in blood flow restriction, it's accelerated by the fact that we don't have metabolic clearance. And this is what actually drives the actual benefit of restriction, because we start to fatigue. Now, we have something called the force-velocity relationship, which goes something like this, meaning that our muscle fibers experience mechanical tension when our contraction velocity is very slow. But this ultimately is driven by how much effort that we're putting into the muscle contraction. So if we're just creating the situation right now where we're fatigued and we're not able to move the weight very quickly, adaptation happens. So with peripheral, that's in contrast to central fatigue, which is our brain just gets tired, pretty much. Our brain just we can't recruit those higher threshold motor units to actually get the activity done. So if we can fatigue our muscles.
Can I interrupt you really quick?
Yeah.
Yeah. Yeah, because I have 30 seconds remaining on this session. Instagram caps at 1 hour. So I would suggest everybody who's still watching, we're going to shortly end that live stream, and we're going to hop right back in a new live stream so we can continue talking about the last points and answer the last couple of questions from you guys. Okay? So I'll see you in a couple of seconds, and we'll restart that live stream. Yeah?
Sounds good.
See you then. Come back on. There you are.
What's up?
Sorry again, Nick. Sorry again that I had to cut you off, but I wasn't aware that there was a time limit of 1 hour. So yeah, but it's good that we hit that time limit. But you were in the midst of answering that question. I'm not sure. What we're talking about. So
just that there's a balance between how much we can actually activate our muscles voluntarily and the subsequent hypertrophy. So typically when we do the one joint approach, for example, we're able to accumulate very high levels of peripheral fatigue, which is going to drive the adaptation process, versus something like a high multi-joint exercise, especially with blood flow restriction, for example, doing over a prolonged period of time, may or may not be the most beneficial exercise selection here. So for me, from my personal perspective, I tend to use a lot of unilateral exercises with blood flow restriction and then get them without BFR, maybe a little bit heavier if they're appropriate, to be able to maximize the systemic and proximal benefits of blood flow restriction exercise. I mean, that's pretty much at the end of the day what it's about. Someone did ask who to follow on Instagram. It's Chris A. Beardsley. He just puts together, I mean, really, the hypertrophy science is so muddled, and what he's doing is an excellent job of just clarifying what drives the adaptation process. And ultimately, it is mechanical tension. And so mechanical tension, if a muscle fiber can experience mechanical tension, right, from a weight driving like this, then we have all of this force that's exerted on that muscle fiber, which is going to drive the muscle fiber to actually get larger. And so his work is just trying to bring to light that fatigue is the ultimate driver of that adaptation process, and we can accelerate fatigue in light loads with blood flow restriction. So
awesome. Yeah, maybe let's wrap it up. I think we got through the questions that were asked most often in our stories, but I think we want to give the chance also to people who still had questions during that live stream, that we can go in and answer those. So I don't know.
Yeah, if there's any other questions, for sure.
Let's see. I'm just gonna.
I know there was a couple. There was a couple other questions that were listed on the last live stream that I couldn't see.
Yeah. So anybody who posted a question in the first part of this live stream, if you want your question answered as good as possible, you can post it in the comments below again, and we'll try to answer it again. And of course, also for those of you who just tuned in, the live streams, they're going to be shared for 24 hours, and Nicholas was also recording. So we are going to post those up on social media again, and you can watch the entire live stream for the next 24 hours on our profile.
All right, so first question was hypertrophy blood flow restriction training. So it's actually universally accepted now. It's without a doubt in the research now that blood flow restriction can promote equivocal hypertrophy to high load training, especially when the high load training is taken to failure, right? And when high load training, I mean like 85% of the 1 rep max. So muscle, as I said before, is very non-specific. So as long as we're taking that muscle to a significant stress, it doesn't matter what load that is. Tendons, on the other hand, are very specific. So that has clinical implications. But in terms of hypertrophy, it's really just as long as we're able to get we're able to accelerate the fatigue, which is going to be able to lower the threshold for adaptation with light loads. So equivocal. Exercise
there's a good. Yeah, I think there's a good question. Also, if you feel safe administering BFR with your patients in practice, is there any also home application possible for patients? I think that's a good question. But
Excellent.
Of course, I guess that also concerns the devices themselves. How practical are they to apply personally as part of maybe a home exercise program?
Yeah, that's a great question. So prior to, really last year, there was only one device, the Delphi unit, that I really would feel comfortable with having with using in clinical practice. But recently, there has been the development of a SmartTool SmartCuff, which is an affordable option for blood flow restriction, that we actually are piloting having clients take it home. Because a lot of the protocols that are for the post-operative client are involving high-frequency applications of blood flow restriction that are not clinically feasible. And so what we're doing now is we're either selling these cuffs or we're renting them to these clients to be able to use and be able to augment their rehab process. So it really just depends. And honestly, with these cuffs, as long as you're able to standardize the pressure to the limit, their individualized pressure, it's a pretty safe way to be able to do that. So I'm not that concerned as long as the individual has the, is made clear of, what we're actually doing in the process itself. So it's pretty low key.
Yeah. And it's not a complicated process of applying it.
No,
I guess
it's not a complicated process at all. So it's really, and that's where we get involved. If I have some the use of a cuffs at home, it takes one session to be able to integrate them into being able to apply it. So it's really not that complicated.
Okay. Yeah, I know there's a lot of questions that we discussed in the live stream, so I encourage you guys to go back after this and rewatch the live stream, and also be sure to follow, of course, Nick on his page at the HPM, because he answers a lot of those questions in really regular posts and that are easy to understand. And we're also going to post a couple of posts leading up to next week from this live stream. Otherwise, we're going to be here the entire time and repeating those.
I think there's one question. There's one question about, do you leave BFR on during sets or allow reperfusion between sets? This is actually a really cool application of blood flow restriction, in that fatigue, right? With continuous blood flow restriction, which is what it would be called if we kept the blood flow restriction, the actual cuff on the entirety of the exercise. Continuous blood flow restriction is going to, again, trap those metabolites that are going to drive the fatigue process. Well, with intermittent blood flow restriction, you can actually drive that fatigue process while during the rest period. So, for example, if we're using, and this is, if you follow my Instagram, I've been kind of leading up to this. I haven't released this kind of publicly per se, but there is evidence to suggest that as you bridge the gap between someone that's injured and can't handle heavy loads, you can then bridge the gap to heavier loads by then doing blood flow restriction during the rest periods, but using a little bit heavier load. So that load, now you're going to stress the tissues a little bit more, but then you're trapping those metabolites that are going to be built up during the exercise, and being able to then continue the fatigue process, or accelerate the fatigue process, while still doing a little bit heavier loading. So there's a couple different approaches that you can do. I will start to elucidate some of the thought processes as I continue to use it on myself, but also my clients, and the successes with that. So. All right. So I think a health coach, I think that the 30-15-15-15 protocol is a great introductory protocol, because you're accelerating you're creating that energy mismatch in the first 30 reps, and then those 3 sets of 15 tend to be those work sets. But do I adhere to that 30-15-15-15 all the time? Absolutely not, because I'm a big principles guy, so if you understand the principles that blood flow restriction accelerates the accumulation of peripheral fatigue, then you don't necessarily need to be married to that 30-15-15-15 protocol.
All right. I think maybe let's do the last question here. When do you feel safe to increase the pressure on the cuff? At what point do you decide this, looking at to prevent training benefits plateau? or is there a training benefit plateau, and how does maybe also training effects correlate with the pressure that of occlusion you're
that's a great last question too, because there is a lot of relationships that are at play here. There is a relationship between load and pressure, meaning that as soon as, if I'm not using any load whatsoever, I actually want to get to a period of time where I'm using very high pressures. Under the assumption, if we're not exercising to failure. If we're exercising to failure, none of this matters, because ultimately you can then use lesser pressure as long as you're able to exercise to failure. The problem is, as I mentioned in the last live stream, is that the closer and closer you get to failure, the longer and longer you go in the exercise, the more painful it gets, and the more likelihood that you're going to elicit some muscle damage in the first 1 or 2 week periods. So typically what I do is I will start off with lesser pressures and lesser load, and then I will increase the pressure before I increase the load. And then once I get to a load, a period of like 80% in the legs or 50% in the arms, then if I am able to increase the load, I will then be able to reduce the pressure. Because as soon as you start to increase the load, you don't necessarily need to have as high pressure. So ultimately, that's one relationship. Then there's the perception of pain and pressure. So the higher the pain or the higher the pressure, the higher perceived pain and exertion that's going on in a non-failure exercise. And so it's balancing all of these, which is why I'm a big principles guy, and knowing that my whole process for me is to make sure that they're getting a training effect at light loads. Well, then pressure becomes a variable that I can manipulate, load becomes a variable I can manipulate, and even the rest period becomes a variable I can manipulate. So that's kind of my thought processes there.
Awesome. Very cool. So I think it's time to wrap it up here. We've talked for, more than a good hour here on Instagram. Thanks again, Nick, for tuning in. I still want to give you also the time to plug all of the social media outlets you have available. Where can people find you and learn more about you?
So everyone can find me on first and foremost, my Instagram channel, the HPM. I have probably the most content on blood flow restriction on the internet, especially on Instagram. I post all the time. It's just my passion project. I love it. I also am a co-founder of the BFR Pros. So we work with high-level athletes on blood flow restriction programming. So you can follow the BFR Pros at the BFR Pros and check out our website. We work with high-level, anybody that's really wanting to accelerate their human performance and recovery with blood flow restriction. We are in the trenches, and obviously, my good buddy Mario Novo at Lifters Clinic. He's also another good one to follow for exercise as well as blood flow restriction. And we're all just doing a lot of crazy things with BFR, and we're very grateful that we have this avenue to be able to just get this information out there. Because, I don't have any cuff allegiances. I just want to make sure that evidence-based blood flow restriction is landing in clinics and gyms all across the world. So my job here is to just convey that information from the research and also from the in the trenches experiences with both myself, but also with the athletes and the clients and patients that I work with. So again, thank you so much, Andreas, for the opportunity to just come on here, and I hope everyone watching this can just be able to get some benefit from this in their own life. So
yes, thanks also from me to you to come on here and provide lots and lots of value to our community. That's some information that we ourselves maybe we could research, but why not talk to the experts, I think, in the field and have this conversation right here if we can really leverage the medium for the both of us. Thanks again. We're going to post a couple of posts together the coming week, discussing some of the answers that we gave during this live stream. So you can also read up on it if maybe some information was hard to consume on here. The live stream is going to be live for 24 hours and probably also on other social media channels. We're going to try to get them up on maybe Facebook and YouTube as well. So thanks again, everybody, for tuning in. I hope you enjoyed this live stream. We're going to try to do this a little more with different people from our community so we can provide more diversified value and more diverse content to you from the world of physiotherapy. So thanks again for tuning in. I hope you have a great Sunday, and we'll see you next time. Bye.
Thank you.